Hello, welcome to this program of cancer immunotherapy called Evolving Paradigms in Cancer Immunotherapy. So what we're going to try to do today with you is to have a review of biomarkers, combination therapy, and why we use PD-1, PD-L1 pathway. And I'm going to try to give you an understanding of the immune system and why the immune system can be an active way to treat cancer here. And as you know, this is actually a very enthusiastic part of the cancer therapy here. So I'm a medical oncologist in Gustave Roussy from the genitourinary group, and I have been part of the immune therapy development for more than 20 years now, and you can see my disclosure here. So, what do we know about cancer therapy? And if you go back to the old age, of course, I mean, the first time we hear about cancer in the old age was when removal of the first cancer was done in 1846. So that was the time of surgery, and of course the first surgery were not very successful. But removing cancer is now, of course, part of the treatment we have. Radiotherapy was introduced in 1901, so it's more than 100 years ago, and we have the first machine here, and as you know, we've done a lot of progress in terms of machine, in terms of the way we use radiotherapy and stereotactic radiotherapy as an example now. Chemotherapy was then introduced here, and as you know, chemotherapy, the goal is to stop tumor growth, to block the tumor growth, and to try to induce apoptosis, whatever the tumor are. So it's not a question of the type of tumor so far. We tried a lot of different agents, a lot of different ways to block and stop tumor growth. And chemotherapy has been very useful for many tumors here. But recently, I would say in the past 20 years, two new concepts certainly came to cancer therapy, which are going to change the way we treat cancer here. The first concept is what we call targeted therapy. So what do we call targeted therapy? Targeted therapy means that we have a target on the tumor cells. As an example, we have a specific antigen which is expressed that we can target with an antibody, as an example. And of course, blocking this antigen might be a way to block the tumor cells. Give you a few examples. HER2 for breast cancer, c-KIT for GIST tumor, VEGF for tumors which express VEGF highly, like renal cancer. So this is, of course, we target the tumor now. Sometimes we target the microenvironment in the vessels, but we mostly target the tumor, HER2, c-KIT, EGF as an example. This is what we call targeted therapy, with usually small molecules or antibody which are going to target a specific place of the tumor here. What is new also is to try to use the target host as the target of our treatment here. Not anymore the tumor itself, but the host here. That's what we call immunotherapy. And if you think about it, it makes sense to target the immune system because our immune system is key in terms of balance between having or not having strange cells in our body here, like tumor cells here. So is the immune system and immunotherapy new? No. I mean, this concept has been used for many, many, many years. This is the first approach to use immune system, which is we call by Coley, which we use a toxin injected into the tumor to try to stimulate the immune system here. Go back 1899. And what he did at that time was to inject into the tumor some toxin here, inducing in some patients very dramatic tumor shrinkage, probably and maybe going through PD-1 and PD-L1 interaction here. And that's something we're going to speak about now. So of course, going from toxin to PD-1 is a more sophisticated way, but that's still a way to use the immune system the best we can here. So what do we know about cancer and immune system? So what we know is that the microenvironment into the tumor is made of very different cells here. Some are good, like T cell, like antigen-presenting cells, which are usually very important ones, dendritic cells, of course. Some are bad, like MSDC, myeloid depressing cells, like some other cells. And also we have some very important negative factors here. So some will induce tumor suppression, some will induce tumor progression. And of course, the goal of our new treatment, cancer immunotherapy, will be to put the balance in favor of tumor suppression here. So knowing all these guys is important to try to understand what we're going to do by using the immune system now here. So just start with a small video to explain you why and how the immune system is working against cancer here.
The main functions of our immune system are to monitor tissue homeostasis, protect against pathogens, and eliminate damaged cells. Research in recent years has shed light on the relationship between cancer and the immune system, and has positioned the immune system as a crucial regulator of cancer development. Cancer cells can avoid detection and destruction by immune cells. This can happen through making detection more difficult by reducing the expression of tumour antigens, expressing proteins that induce immune cell inactivation, and inducing cells in the microenvironment to release substances that suppress immune responses and promote tumour cell survival. While the immune system is important for recognising and eliminating tumour cells, it also plays a critical role in tumour progression. This dual role of suppression and promotion is termed immunoediting and consists of 3 phases: elimination, equilibrium, and escape. During elimination, most cancer cells are destroyed by the immune system. Certain tumour cells that survive immune destruction enter the equilibrium phase, which is characterised by immune resistance. The escape phase is the final step, where immunologically resistant tumours grow and establish an immunosuppressive microenvironment. As a result of this process, immunotherapies that stimulate the immune system or counteract signals produced by cancer cells that suppress immune responses have been highly sought after. For example, immune checkpoint modulators help stop immune checkpoint proteins from suppressing immune responses. This allows the immune system to become more functional, increasing its ability to destroy cancer cells. A second method is immune cell therapy. In one strategy, T cells that have infiltrated a tumour are collected, and those that show the greatest recognition of tumour cells are selected and grown. They are then activated by cytokines and reinfused to help shrink or destroy tumours. A third approach is antibodies. For example, antibody-drug conjugates link antibodies to a toxic substance that is delivered to a cancer cell when the antibody binds to it. Other antibodies induce apoptosis or recruit other immune cells to destroy the target cell. Ultimately, these immune-related methods continue to show promise in the medical management of cancer.
So I hope you enjoy this video. So what you have fully understood at least, is that the anti-tumor effect is a dynamic process here. So of course, what we have to induce immune system activation, we first have to release the cancer cell antigens, which is the first step, usually by cancer cell death or by expressing the antigen at the surface of the cells, which is sometimes happening here. Then when this antigen is released, this antigen has to be presented to the immune system. And that's the job of antigen-presenting cells, macrophages, dendritic cells, which are what we call generically APC, antigen-presenting cells. These APC now are going to prime and activate the immune system, mostly T-cell activation, which is the next step. Very important step, of course, necessary to induce further on killing of the tumor cells here. But these activated T cells now have to traffic, and of course they have to traffic to the tumor cells, which is an important step, of course. If you activate the T cells outside of the microenvironment, it's not going to be good. Then these activated T cells have to infiltrate the tumor microenvironment. They have to be into the tumor. That's what we call CTL, activated T cells here. And of course, these are going to be part of the immune environment here. They will have to recognize the cancer. So T cells should have to recognize the cancer, and then they will have to kill the cancer cell. So that's the global process, which is, of course, a dynamic process, which requires different steps here. First of all, activation of the immune system, but also trafficking of the activated cells up to the tumor microenvironment to kill the cells. So as there is different steps, of course, there is different ways that the immune system is going to escape and to avoid that these T cells are going to work here. So let's go back to the concept of checkpoint inhibitor. So activation of T cells require different steps. The first step is, of course, presentation of the antigen to the immune system. That's the first step, which is absolutely unnecessary for activating the T cells here. This goes through antigens and T cell receptor here, which is going to look at the antigen and get activated. But we need a positive signal here. Presentation of the antigen is not sufficient here. We also need a positive co-signal. Here it's CD28B7 interaction here. So this is activation of T cells, two signals, antigen presentation, positive signal with CD28B7 interaction here. Interestingly, we also have negative co-signal here. With the T cell presentation with antigen, we can have negative co-signal here. We have two examples of negative co-signal here. One is PD1, PDL1 interaction. One is CTLA4-B7 interaction here. And you can see that B7 can be induced both in positive and negative co-signal here. And this negative co-signal is going to inhibit the T cell activation here. When you think about the immune resistance, which is going to occur, unfortunately, in many situations, you have two ways to have immune resistance here. One way is to have an innate immune resistance. What does it mean? It means that from the beginning of the antigen presentation, antigen activation, you have this negative co-signal activated. So you have PDL1 expressed on the tumor cells, you have PD1 expressed on the T cells, and from the beginning, you have PDL1, PD1 interaction and blockade of the immune system. That's what we call innate immune resistance. We also have adaptive immune resistance, which is induced immune resistance. So initially, you have an activation of the immune system. But then, because of different activation of pathway, like STAT here, you have PDL1 expression of the tumor cells and further PD1 expression of the T cells, which is going to be the negative co-signal. So initially, the immune system is working, but then you have adaptive immune resistance. There are two different resistances, but in any way leading to resistance to the immune system, which is unfortunately what we see in many cancer situations where patients develop cancer, despite they have an immune system, which is not able to work against cancer development here. So obviously, resistant mechanism to immune checkpoint is part of different way, and you have different factors here which explain why immune checkpoint inhibitors are not able to fight against every cancer here. This is what we could call the cancer immunogram here, and you can see here the different players here. So we'll go through some of them here, but as an example, tumor antigens load, or what we call mutation load, is important. The more you have antigen, the more probably you can activate the immune system. It makes sense that the mutation load is part of the important activation system of the immune system here. You also need to have lymphocytes. If you don't have lymphocytes, you cannot activate the lymphocytes. So lymphocyte count is important also in terms of what we actually should do with our immune system here. We should also have infiltration of the T cells within the microenvironment and within the tumor cells here. So this immune T cells activation, infiltration, is part of the phenomenon here. Of course, PDL1 is important here. If we can get rid of PDL1, you understand that the negative co-signal is going to disappear. So certainly PDL1 is going to be part of the phenomenon here. We also have inhibitory cytokines such as interleukin-6, CRP, TNF, etc., etc. These are important cytokines which are going to inhibit some of the T cell, some of the function of the T cell here. And then we have important phenomena which are not yet so much used, but like glucose uptake. And you know that tumor cells need glucose to grow here. So we can deprivate the tumor cells from glucose as an example. We might also help the immune system to work better here. And finally, we have expression of the molecule of MHC, interferon gamma sensitivity, of course, are also important part of the way resistance mechanism to immune checkpoint. Let's go back now to a very simple cartoon to explain you a brief way to explain why we use PD-1 and PD-L1. So very simple cartoon, but very easy to understand PD-1 and PD-L1 interaction. So on the left you have antigen-presenting cells, on the right you have T cell here. So what's going on here? You have antigen recognition, T cell recognize the antigen, and then you have a signal too of co-stimulation. Just remind that you have positive and negative co-signal here. And that's this balance which is very important to explain why immune system is going to work or not. Co-stimulation is key and is absolutely compulsory for the immune system activation or desactivation here. So this positive co-signal, first positive signal is antigen presentation here. And then we have this second signal, which is either positive or negative. And what we have here, and what we're going to speak about mostly, is a negative co-signal here. And there is a series of positive and negative co-signal, but just focus on the negative co-signal here. So the first one, which is of interest, of course, because that's a part of most of the new cancer immunotherapy program here, is PD-1, PD-L1 interaction here. PD-L1 is expressed mostly on tumor cells, PD-1 on T cells, and this negative co-signal is going to make a break on the immune system here. That's not the only one. As you can see here, you also have CTLA4, B7 interaction, which is a negative co-signal here. And just look at this cartoon here. You can understand that B7 can be activated by CD28 and inhibited by CTLA4. So that's both positive and negative co-signal which can occur here. So two important negative co-signals, CTLA4, PD-1, interaction with PD-L1 and B7 are here, negative co-signal here. So just have now a video to better explain the PD-1, PD-L1 pathway, which is of course one of the most important pathways we are going to target for cancer immunotherapy nowadays. Let's look at the video now.
In recent years, immune checkpoint blockade has taken centre stage as a significant breakthrough in medical cancer therapy. Activation of T cells involves several paired molecular interactions, such as T cell receptors or CD4 with the major histocompatibility complex, B71 with CD28 and several others. Programmed cell death 1, or PD-1, is a member of the CD28 superfamily and is expressed on T lymphocytes. PD-L1 and PD-L2 are its ligands on cancer cells. Mechanistically, T cells use PD-1 to probe cancer cells for PD-L1 and PD-L2. When they find it, they leave tumour cells alone to survive. When PD-1 binds to its ligand, it induces immune suppression in the tumour microenvironment, which subsequently leads to resistance of cancer cells to the immune system. However, when a molecule blocks this identification, T cells are no longer misled by the presence of PD-L1 and PD-L2, and subsequently rally an immune system attack on the cancer cell. Antibody-based PD-1 or PD-L1 blockade has achieved strong success in clinical trials. These agents take advantage of specific binding to antigens and thus have been widely used for immune checkpoint blockade. Multiple PD-1 or PD-L1 antibodies have been approved for clinical use or have entered into clinical trials, including nivolumab, pembrolizumab, atezolizumab, durvalumab, and avelumab. The first clinical trial of a PD-1 blocking agent began nearly a decade ago in patients with blood cancer. Today, more than a dozen trials have been completed, with more than 50 underway, involving thousands of patients with several different types of cancer. These ongoing trials are encouraging, particularly since they indicate that a substantial number of participants have benefited, resulting in a need for further trials. Additionally, they have suggested that these agents may be effective against multiple types of cancer.
So let's go back now to our simple cartoon here, PD-1 checkpoint pathway here. So as I told you, presentation of the antigen to the T cell, positive co-signal with CD28B7 lead to activated T cell. And these activated T cells are going to produce very important part of cytokines, such interferon gamma, and induce proliferation of these T cells, and of course cytotoxicity against tumor cells here. That's not only against tumor cells, that's also against bacteria, against viruses, of course. And that's why the immune system is working. Checkpoint inhibitor is not only for cancer cells. Just understand that this immune system has been mostly built for fighting against infection here. So the brake is now going to be put on because the immune system should not be activated all over the time, because if it's activated all over the time, you might have immune-related adverse event we'll speak about later on here. And one way to give a break to the immune system is to activate some negative co-signal here. And PD-1, as I told you before, is one of these important negative co-signal which is induced by cytokines and proliferation of the T cells, which is going to relate with a PD-L1 expression of both antigen-presenting cells or tumor cells, if we speak about cancer immunotherapy here. And this negative co-signal, as you know, is going to change what we have as pattern here. High cytokines, high proliferation, high cytotoxicity to exhausted T cells, which are not going to be able to proliferate anymore, to induce cytokines like interferon gamma anymore, and to induce cytotoxicity anymore. Immune system is exhausted, is not working anymore against cancer. And that's what we observe when patients develop cancer. Our immune system is not able anymore to fight against cancer here. So is PD-L1 expression linked to some prognostic factor? Yes, it is. Just look at this old study now in kidney cancer, 2004. The Mayo Clinic group showed that PD-L1 expression was important in kidney cancer and had a prognostic value, which means that the more you express PD-L1, the more the outcome is worse. So is it only in localized cancer? No. It has been replicated. It's seen in localized, in metastatic cancer. If you express PD-L1, your outcome is going to be worse. So targeting PD-L1 makes really sense in different cancer. So go back to our exhausted T cell system here. So we have PD-1, PD-L1 interaction, which completely blocks the immune system here. So why not to try to release the immune system by releasing the brake between PD-1 and PD-L1? So what can we do? We can block the interaction between PD-1 and PD-L1 by trying to restore the immune system here. And that's what we do with antibody against PD-1 or PD-L1. Just explain you why you can act both on the PD-1 side and on the PD-L1 side, and probably the activity is quite similar. The main difference might be in toxicity here, but you can block this interaction both by blocking PD-1 or by blocking PD-L1 here. And due to this blockade, you release the brake, and now you have the immune system which is reinvigorated, and your T cells are able again to proliferate, to kill the tumor cells, and to release cytokines like interferon gamma here. So that's the way we use PD-1, PD-L1 blockade, and that's the way we use antibody against cancer here. And as I told you before, probably effectiveness of these checkpoint inhibitors might be also related to the mutation load here. the more antigens you have, the more you might be able to activate the immune system and maybe to act against cancer here. And in fact, if you look at this cartoon here, you can go from left to right side of the cartoon. You can see on the right side, tumor we have a higher mutation load, which are more sensitive in general to PD-1, PD-L1 blockade here. So it makes sense, and that's something which is still ongoing, but mutational load is important in terms of cancer immunotherapy here. And of course, I mean, there are multiple factors which contribute to generation of activated T-cell immunity or tolerance here. And what we need to have, of course, when you look at this cartoon, is to have a balance in favor of immunity instead of tolerance. And that's what we try to do by combining different approaches and to try to improve cancer immunotherapy. And that's a lot of work which is ongoing, which hopefully is going to lead to not only curing 20-25% of our cancer patients by immune system, but treating and curing maybe 50, 60, and at the end, 100% of our cancer patients with immune system here. So what do we know about immune biomarkers? So of course, I mean, there are different compartments in cancer which are part of the immune biomarkers here. So the tumor is important here, and that's where we look at PD-L1 expression. We look at the TIL, tumor infiltrating lymphocytes, which are important part of the immune system here. We also have an important compartment, which is a lymph node, where we get lymphocytes activated, which are very important part of the immune system, which look at activation, proliferation, antigen stimulation here. And finally, we have blood vessels, which of course are required, I mean, to get the T cells to the tumor cells. So having good blood cells and blood vessels is very important here. So that's part of the immune biomarkers we might look at when we look at the effectiveness and predictivity of cancer immunotherapy here. So one very important point we actually have, and which is part of the work many of us are doing here, is how can we modulate response to checkpoint inhibitors. So we had in the past 5 to 6 years very enthusiastic results with checkpoint inhibitors. We want to do better than what we do actually, curing 25-30% of our patients. We want to go higher, of course. And there are different ways to improve the way we are going to modulate our checkpoint inhibitor. Of course, one way is to combine with what we already do, radiotherapy, chemotherapy, targeted therapy. There are different approaches depending on tumor types where we combine checkpoint inhibitor to these different approaches here. We can combine with some cytokines, which have some tumor effect, which can induce more immune system here. We can combine to other checkpoint inhibitor. The first one to have been combined with PD-1 and PD-L1 blockage is anti-CTLA-4, which is, as I showed you before, a negative co-signal. But we have a lot of other candidates as checkpoint inhibitor, and you can think about LAG-3, TIM-3, OX40, etc., etc. So a lot of other candidates which can be also primed and targeted by the immune system here. You can try to improve trafficking of T cells, but you can also try to improve vessels and blood vessels activation. So anti-VEGF agents are very important too, not only probably in tumors where VEGF is so important like kidney cancer, and this combination of anti-VEGF and PD-1 is very key in kidney cancer, but it might be also a way to improve the activity in other tumor types, and that's actually ongoing in different clinical trials here. And finally, maybe combine anti-PD-1 and anti-PD-L1. This is also one actual interesting approach, which might be to combine both blockade on the T cell and the tumor cell side, which can also synergize to improve the way immune checkpoints are working here. So what do we have as cancer immunotherapy results? So I'm just going to show you a few clinical trials just to give you an idea. Of course, it's not going to be all tumors, but I'm going to just select a few of them to show you some idea of what we have here. So just start with what we had as cancer immunotherapy agents approved, and it's changing every day. So maybe when you will look at this program, I mean, you will have a lot of new agents approved. But you have some anti-PD-1 approved, nivolumab, pembrolizumab. You have some anti-PD-L1 approved, atezolizumab, durvalumab, avelumab. You have anti-CTLA-4 antibodies approved, like ipilimumab here. And that's very important for you to become familiar with these agents because they are growing and growing and are becoming part of our treatment for cancer. And you will use them certainly in your patients very shortly here. So let's start with urothelial cancer here. So this is atezolizumab, a PD-L1 antibody, and as you can see here, using this antibody, especially in patients who do have PD-L1 expression, and this test look at PD-L1 expression in the immune system here. Those patients who have high PD-L1 expression by this test has a much better survival than those patients who don't have expression. So very good outcome in patients who express PD-L1 in the immune system here. Pembrolizumab, which is a PD-1 blockade, is active after cisplatin here in urothelial cancer, and that's led to approval of this drug. You can see that both overall survival and PFS are significantly improved. And interestingly, what is more important too is that we have long durable responses, maybe some cure of patients that we have never observed before in urothelial cancer by using PD-1 or PD-L1 blockade here. And that's the same with nivolumab, active in urothelial cancer. You can see that the confirmed objective response rate was around 25%, which is interestingly what you will observe in many tumor types with PD-1 or PD-L1 blockade, 20 to 30% response. You have a good partial response rate here. And interestingly, there is no difference with the tests that nivolumab people are using by PD-L1 expression on the tumor cells. So maybe some differences in the test between PD-L1 expression in the tumor or PD-L1 expression in the immune system here might be different in terms of predictivity of the activity of the drug. So this is the survival in urothelial cancer with nivolumab, much higher than expected with classical treatments that we used before here. So another drug has been active in kidney cancer, which is durvalumab. Durvalumab is a PD-L1 drug which is also developed in urothelial cancer. You can see on the slides that the response rate was very high in patients with PD-L1 expression, which is a combination of T cell and tumor cell expression here. So this test seems to be quite predictive of the activity. You can see that the response rate is much higher in patients patients who express in their tumor PD-L1 than those who don't express PD-L1 in their tumor. So it's a combined both tumor cells and immune cells infiltration here, which seems to be predictive here. So finally, avelumab, which is also a PD-L1 blocker, is active in urothelial cancer. This is a pooled interim analysis of 2 cohorts of patients treated with this antibody here. Median PFS was promising also, and median OS was in the same range of what has been shown with over patients with urothelial cancer here. So PD-1 and PD-L1 blockade is active in urothelial cancer, of course, and has led to approval of different agents in these tumor types here. If we now move to renal cancer here, the first drug to have been approved in kidney cancer was nivolumab. So nivolumab was tested in patients who were refractory to TKI, 1 or 2 TKI, in a big study called Checkmate 25. So in this study, nivolumab was compared with everolimus, one of our standard of care. And you can see that the response rate, once again, 25%, is much better than we have with everolimus here, with, interestingly, improvement in overall survival here. Atezolizumab is also active in metastatic kidney cancer here. So this is some of the data coming from a phase 1 study in kidney cancer. You can see that almost 50% of the patients do have tumor shrinkage, and around 20% of the patients do have response rate in these patients treated with atezolizumab here. So that's interesting that we seem to have a kind of correlation with also the immune activation with PD-L1 here. So there's a trend that PD-L1 expressing cells do respond better to atezolizumab here. And this was the median overall survival from this initial study, looking at 29 months median overall survival in highly pretreated patients with metastatic kidney cancer, which looks quite exciting in terms of activity of this drug in metastatic kidney cancer here. So if we move now to non-small cell lung cancer, another tumor where PD-1 and PD-L1 blockers have been shown to be active, this is an interesting study looking at PD-1 blockade versus chemotherapy here, single agent versus docetaxel here. So what has been shown in this study with nivolumab here is that if you look at comparison between PD-1 blockade and chemotherapy, you have an improvement in overall survival when using this PD-1 blockade, which is highly significant in terms of hazard ratio here. And one of the questions is whether some tumors, some lung tumors, respond differently from others one. And if you look at non-squamous versus squamous, it doesn't seem to have a difference in terms of hazard ratio between non-squamous and squamous lung cell carcinoma here. So as I've shown you before, one way to improve these results, which are good but not good enough, to cure all our patients here, is to try to combine therapy with PD-1 and PD-L1 blockade here. So the general concept is, of course, that PD-L1 expression is to go over time and increase over time, and the more PD-L1 expression you have, the more response rate you should have here. So the key is to have PD-L1 expression, and the idea is to try to increase PD-L1 expression, to increase response rate at the end, and go to this high response rate that we all want to get to cure patients with cancer immunotherapy here. So what we need to do for that is to reduce T-cell regulatory cell activity, so that's important what, enhance cross-presentation of tumor antigens, and at the end increase tumor PD-L1 expression or PD-L1 expression in the CD8 positive T cells here. So that's the idea, to have synergistic effect between chemotherapy and anti-PD-1 or PD-L1 here. And that's something that we seem to have in non-small cell lung cancer. Combination of chemotherapy plus PD-1, PD-L1 blockade seems to be synergistic in terms of combination with nivolumab, pembrolizumab, or atezolizumab here. So attractive way to increase the way we are going to get better response and better outcome to our patients here. And of course, it's certainly dependent on the subtypes of non-small cell lung cancer. Some will be more sensitive to chemotherapy. Some will be more sensitive to targeted therapy. And, as an example, an ALK-positive lung cancer will be treated with ALK inhibitor. And maybe combining ALK inhibitor to PD-1 blockade in these patients will increase the activity. Some will have EGF expression and will be treated with EGF blocker here. And combining EGF blockade and PD-1 is also important here. So this combination is going to change depending on the subtypes of lung cancer we'll have here. So now if we go to metastatic kidney cancer here, this is some combination of nivolumab and ipilimumab, so blockade of PD-1 and CTLA-4 pathway here. This is a phase 1 looking at 2 doses of nivo and ipi. So on the left, nivo 3 mg and ipi 1 mg. On the right side, nivo 1 mg and ipi 3 mg. 47 patients each cohort here. And what you can see here, response rate was quite high, above 40% here, with interestingly good complete remission rate in the nivo 3 EP1, but also better tolerability in the nivo 3 EP1 group here, which is going to lead to a large phase 3, which is ongoing, and we should get the data from this large phase 3 hopefully soon here. So the final question, of course, is what are we going to get by combining treatment here? And the risk of the immune blockade is to have immune-related adverse events here. And that's something that we observe when we use checkpoint inhibitor blocker here. So what do we know about immune-related adverse events here? So of course the immune therapy is going to do something different than what we do with chemotherapy. Chemotherapy attacks the tumor directly by targeting rapidly dividing cells here. And that's the cancer cells which might make mistakes. And we have sometimes toxicity in non-cancer cells of these drugs that we use for cancer cells here. Explaining alopecia, explaining, of course, toxicity on the hematological cell here with chemotherapy here. When you use immunotherapy, we do something completely different here. So what we get as side effects is activation of the immune system and sometimes overactivation of the immune system. So these activated T cells can act against other organs than the tumor cells here. So what you will see when you will use these drugs, you will see virtually any organ subject to autoimmunotherapy. So do remember that. You will see as much drug you are going to use, you will see some of this toxicity, and you will see toxicity in every organ you can think about. I'm used to say, that's the best way to revise your internal medicine book, because you can see toxicity in most of the organ here. So what are the most important ones you should think about here? On the left part, you have some endocrine toxicity like hypothyroidism, thyroiditis, adrenal insufficiency. You also have some GI toxicity like enterocolitis. You have skin toxicity like dermatitis. You also have pneumonitis, hepatitis, pancreatitis, etc., etc. So this is what you can see and what you will see probably if you use these drugs. Of course, it's only probably 20% of your patients. 80% will have a very good safety profile. But this toxicity you are going to see here. You will have some less common toxicity like hematological toxicity, thrombocytopenia, hemolytic anemia. Some myocarditis, pericarditis, vasculitis can be also seen. You can have ocular toxicity in a few patients and renal toxicity in a few patients. So that's less common, but that's also immune-related toxicity that you can see here. So this toxicity, of course, is going to be a balance between efficacy and toxicity. And of course, what you want to get an immune response. And the more you get immune response by immunotherapy, the more you can get adverse event here. And of course, that's autoimmune adverse event, autoimmune reactions that you can observe in some of your patients here. And you have here a list of what you can get here. Don't forget that you also have some general events due to this activation of the immune system like fatigue, pyrexia, chills, infusion reactions that you can also see in a few patients here. Interestingly, corticosteroids are going to fight against this immune-related adverse event, the risk being to get more immune tolerance, which is one of the risks, which is in fact in theory, because we now know that we can use steroids when you get adverse events without reducing the activity of the immune system here. So we also have a lot of questions. One of the questions, of course, is how long should we treat our patients here? And that's a very important question, of course, to try to reduce the risk of adverse event. If we can reduce the duration of therapy, it would be great here. So just as a provocative case, one patient from my clinic was treated for clear cell RCC with nivolumab here. So she's a typical RCC patient who developed pancreatic metastasis and a contralateral renal mass 3 years after initial surgery. She initially received sunitinib as first-line treatment with stable disease for 6 months. And then when she progressed, she was enrolled in the CheckMate 25 study, so nivolumab versus everolimus here. She was treated with nivolumab, and she developed, after only one infusion of nivolumab, hemiplegia due to an ischemic event, probably not related to nivolumab, but then she stopped treatment and refused to receive any further treatment here. However, what she gets here is to accept it to have scans here. So July 2013 was before nivolumab scan. September was after one infusion, first scan we did. And as you can see, the pancreatic mets were very stable as well as the renal mass here. But interestingly, without receiving any further treatment, in January 2016, all the pancreatic mets have disappeared, and the renal mass is now completely necrotic here. Complete remission, delayed response. She is still doing perfectly fine. She's probably cured by only one infusion of nivolumab. So of course, it's a very exceptional case, but just to explain that some patients will require a very short treatment, actually. And that's what we observe in patients with developed toxicity. We have 1 or 2 infusions and then have durable response because they have a very high activation of the immune system here. Another question is coming with this treatment is whether we should treat beyond progression. And the reason is that we observe pseudoprogression in some patients, both with a PD-1 or PD-L1 blockade in every solid tumor. It has been initially reported in melanoma, but it can be seen in renal cancer as an example here. So that's a study we did to look at treatment beyond progression within the CheckMate 25 study, so the pivotal study from with nivolumab here. And you can see that 142 patients did receive nivolumab post-progression and at CT scan after progression here. And more than 50% of the patients did have tumor shrinkage after progression, and 14%, 14%, did have further response after initial progression here. So that's something that we are actually looking for, who are the good patients to treat beyond progression. And the general consensus is actually that those patients who should be treated beyond progression are patients with good safety profile, of course. No reason to continue in patients with a lot of toxicity to the drug. But also patients who seem to have some clinical benefit, which means no impairment of general condition, no major progression here. And that's in fact what we did in the CheckMate study. If you look at the patient treated beyond progression, TBP, on the left part here, that's mostly patients with good performance status, patients with no deterioration on the quality of life for most of those patients here. So that was the general sense that we did in these patients by treated beyond progression here. So I hope you understand what's going on with the immune system and the cancer immunotherapy. Of course, there is extensive research which has clarified the relationship between cancer and the immune system. And actually, we know much better why immune system is not working and how we can reactivate the immune system, at least in theory here. So we have a crucial regulator of the immune system as part of the cancer development here. So immunotherapies have been sought after very, very, very actively in recent years. They stimulate the immune system. They can act and kill cells. And they counteract signals produced by cancer cells that suppress immune responses here. So we have a lot of checkpoint inhibitors, which are usually monoclonal antibodies, which are available and are actually being studied in many, many cancer indications, almost every solid tumor. And actually, many hematological malignancies have been treated with all these agents: atezolizumab, avelumab, durvalumab, ipilimumab, nivolumab, pembrolizumab are now approved in different indications. And combination of all these agents with classical therapy are ongoing and hopefully will help us to cure more patients in the future. Thank you very much.